Good afternoon, everyone, and welcome to our webinar session. My name is Ingrid, and I'm the Administrative Director at Swiss Medical Gate. If you haven't joined the webinar before, sorry, can I just introduce shortly our company, Swiss Medical Gate. Swiss Medical Gate is an international medical center, and we are located in the city center of Geneva. We work exclusively with Swiss leading medical experts and Swiss leading medical institution. As you may know, we work a lot with medical travel partners. We are pleased to be your bridge between you, your client, and the medical institution in Switzerland that you have chosen. We are there from the beginning of your demand until the departure of the patient, which makes it easier for himself. We work as a medical coordination. We coordinate all the medical service, but we also coordinate the administrative part. All the administrative formalities are taken care for the patient and for the family if is requested is also. Now talking about the webinar, we would like to inform you that our webinar is conducted in English and in Russian. And actually for the Russian speakers, participants, we have a dedicated Russian room. If you like to join that room, our webmaster, Alex, will explain you how it works in a couple of minutes. Alex, can you explain that?
Александр, ваше слово.
Коллеги, партнеры, добрый день. Меня зовут Александр. Сегодня я осуществляю техническое сопровождение вебинара. Все технические моменты вы можете писать в чате, если у кого-то что-то не работает, видео либо звук. Трансляция нашего вебинара подразумевает русский перевод. Для того, чтобы попасть в русскую комнату с переводчиком, вам необходимо написать в чате, что вы хотите попасть в русскую комнату. После презентации врачей есть возможность задать вопросы. Вы можете сделать это как письменно в чате, так и в видеоформате. Единственное замечание, если вы захотите сделать это в видеоформате, вам также нужно написать в чате, что вы хотите задать вопрос в видеоформате, и я вам даю добро на это. Собственно говоря, все. Будут вопросы, обращайтесь в чат.
Спасибо, Александр. Ingrid, it's your turn.
I would like also to inform you that this webinar, as well as the previous one and the following one, are recorded. And within the following weeks, there will be, we will have our own channel on YouTube, and you will be able to watch them on YouTube, depending on the country where you are, with the chosen language that you prefer. Regarding it, the webinar, we have two recommendations. We would ask you kindly to turn off on mute and turn off the camera so to save it. And regarding any question that you may have for the doctors, you have two choices. Either you send them by chat, and at the end of their speech, we will just add them so they can reply. But you have also the possibility to talk to the doctor as well, if you prefer. In that case, you send your request by chat, and our webmaster will connect you to the doctor, who will be able to reply to you directly. The medical part now will be led by the doctors, and I'll leave you with Dr. Rabaeus, who's our Chief Medical Advisor at Swiss Medical Gate. And I wish you a very pleasant webinar, and talk to you later.
Thank you, Ingrid. It's my great pleasure to be here again today for a new webinar from Swiss Medical Gate. My name then is Michael Rabaeus. I'm the Medical Director and Chief Medical Advisor of Swiss Medical Gate. And today's webinar will be devoted to my, how should I say, my preferred domain in medicine, which is cardiology, prevention, and how to save patients when they get too bad. The title today expresses a little bit this in the fact that I will first speak about prevention, And then I will turn over the chair to Professor Christophe Hubert, who will take the other side of cardiology, which is to go through a little bit what is today cardiovascular surgery. So that explains the title of Two Extremes meeting. So I will then start my presentation. If you can help me to put it on.
With your Kindle?
Okay.
Did you kiss me?
Voila. So I will be talking about.
Where is your pants? No. Come.
Okay. So I will be talking today about preventive cardiology. What is preventive cardiology? That means that you want to avoid something, a damage to your heart, but to know how to do it, you will have to check your present state. So that's what I will be talking about today. First, how do you do this check? I mean, how do you check where you are? Checkups is something I have been doing for the last 25 years very regularly, and it has led me to understand a certain amount of things. One is that the checkup should not be designed, as is the case in many places in the world, so as to cut the people into maximal amount of small pieces to absolutely try to discover something which is wrong. This has been proven that it does not really bring anything to the patient. And instead, what I try to put forward is the necessity to evaluate what I call the state of health. I mean, people are not feeling really maybe something, and I want to know, are they really in good health or not? But that is a global component. And once you have determined that state of health, then do you need to improve it or not? And if you are in a good state, how do you maintain that? When we come to cardiovascular, I now limit myself to that in the checking, cardiovascular prevention, we usually distinguish between what we call primary prevention, which means you have not had a problem up till now and you would like to avoid something occurring. And to that you have secondary prevention, when you have had a heart problem, but you would like to avoid something new happening again. That was very different for very long, but we are finding out more and more that the preventive efforts, which I will come back to later, remain fundamentally the same. I wanted to underline also something to which I am extremely much attached, is that prevention is something that is profitable to the patient, ultimately. Because what we want is that he should avoid falling sick, and if he has some problems, he should become less sick. In other words, and that's why I put a smiley behind it, I sometimes maintain that efficient prevention is very much against medical business because it keeps the patient away, if I may put it like that. Now, when you do a cardiological checkup, what are the basis of that? I insist personally very much on the absolute necessity of a good consultation to get to know the patient and for him to get to know me, for that matter. And that's very important to understand if there are things that he might not be saying directly and that I need to look into. And it also allows to understand how his medical history has evolved up till now, how he is feeling about that, etc. A very important factor is the lifestyle estimation, because I have found out for many years that by doing what is done at some places, that you fill out a questionnaire on your lifestyle, there is nothing as easy as to fill in as a questionnaire where you know the good answers in advance. So people very often do not answer really exactly. So it needs talking about especially physical activity and nutrition, smoking, the amount of smoke, etc., etc. The blood test for a cardiological checkup is not very extensive. It is usually involved or inserted into the blood test of a global checkup, but what we really test are what are the biological effects of lifestyle, for example, or certain risk factors. Then what is very important is the exercise test, not just to check on the electrocardiogram, which is, I tend to say, really very often the least important. What is very important is truly the performance of the heart. Is it able to increase the pulse rate? Is it able to increase the blood pressure as it should do? That's what it's supposed to do. So you check on the heart performance and you check on the global performance. Just what is the physical performance of the patient? This remains one of the most accurate risk factors that we actually have. An echocardiogram is sometimes used. It's not necessary all the time. I do it very often, mainly to check on the muscle function, especially the muscle thickness. I added at the end coronary calcium score. That's a low dose CT scan that's reserved for some specific cases where you want to be a little bit more accurate on the risk determination. So that's what I usually do on a cardiological checkup. Now, the results are what? Well, in some people, everything looks absolutely perfect. Tant mieux, that's better, all the better for the patient. And the discussion during the second consultation, which is very important in this matter, is to go through what are the means to keep this excellent situation and to continue to prevent the appearance of new problems. And that means, as I will come back to, working on lifestyle very, very strongly, because it is important that everybody realizes, it's not very popular always as a message, but 80% of the risk of having an early heart problem is related to lifestyle. And that's very important. But it's true also, and that's why I perfectly agree, is that explaining lifestyle, etc., it has to be done in a good manner, as I will come back to. On the other side, you do a checkup and something abnormal is found, and most of the time it is the presence of a probable coronary artery disease, plaques on the arteries. For very long, the traditional reflex when you had that suspicion very strongly was that you went in and you looked for a stenosis on one of the arteries, and you then usually went for the implantation of a stent, which seemed absolutely obvious. As we will come back to, it's becoming a little bit less evident that this is truly the best thing to do immediately. It seems evident, as I said, but one has to realize that the narrowings that are evolving slowly are not very dangerous per se. It's the acute obstruction, the rupture of the stenosis, which are responsible of the very severe complications. And to stabilize the plaque, I'm sorry to come back always to the same, one of the major means is by changing your lifestyle correctly. It stabilizes the plaque and diminishes the risk of rupture. It has also to be said, and that's something I have noticed in many patients, if you can convince them to really start exercising by, if they have arteries which are not delivering the efficient amount of blood to the muscle, the heart will start constructing new arteries, so-called collaterals. And that will make things much less dangerous. So the effects of lifestyle, apart from the smoking cessation, I will not go into. I think everybody knows that this is something that we really should stop, because also its effects on the lungs and etc. But physical activity is much less well known, that this is not just something hygienic. This is something that was imposed on mankind for millenniums. And apart from the fact that it helps the heart to work, because the heart is designed, as Professor Huber will show you later on, the heart is really designed for working, for pumping blood. So if you don't make it work more, it doesn't really like it. So that's and the effect is the same on the blood vessels. So that's very important, the physical activity, but it also has an antioxidant effect, and many of you probably know that this is highly in favor of better health. It is a strong anti-diabetic and anti-hypertensive action. I have tens of patients who have stopped the medications because they were able to take up regular exercise. What is maybe less well known, but very interesting, that it also stimulates very strongly the production of stem cells. And of course, it works on the skeleton, on the joints. It even has an antidepressive action, which makes it really one of the most important factors of prevention in our patients. I'm sorry for the noise behind, it's just a helicopter bringing in somebody. The nutrition is also something which has been talked about a lot, and that is something that I go through with the patient very, very much, because a lot of things that have been said are turning out to be not very close to the truth. For example, that you should eat much less fat and no cholesterol. That is has turned out to be not true. And the healthy diet is not designed to keep the cholesterol low, but it's there to help to keep the body to maintain a healthy state. And that's something that one has to go through with the patient very strongly. So what does all of this mean? It means that revascularization per se is not necessarily the first line of treatment when you have a narrowing of one of the arteries. And it's true that several recent studies have shown that stents do not prolong survival in a coronary population. I do personally not think that this means that we should stop stenting. No, it means that we have to go a little bit further in trying to understand who is actually in need of a stent, who will profit from it, and who will be harmed by it. And that's something that we probably have to start looking into. Then on the other side, if we go very far, if the three vessels, we have three main vessels on the heart, bringing blood to the heart. If two are blocked and the third one is narrowed to 90%, you don't have to discuss very much. You need to do something, because when there's no blood at all, then you can't go on. What I mean by all this is just that very often that's what I try to do after these checking, etc., is that one starts with a medical treatment, meaning drugs and lifestyle intervention, and then one see how that can help things. The medication, I will not spend much time on that. It is mainly introducing what we call an antiplatelet agent, of which the aspirin is the most well known, and then treating and possible diabetes, hypertension, etc. Those are common medications. But again, they are used if you have already complications of your lifestyle. And then, as I said, lifestyle is, and do repeat myself, but it's extremely important, and it has been too often seen as an additive treatment, but it's actually the fundamental treatment. It is not, as I said, hygienic. And I'm not thinking that the good old days were that's not what I'm thinking about and regretting. It's just that mankind had to live in a certain manner for several thousand years, and we changed that very brutally after the Second World War. And just to remind you, things like type 2 diabetes and hypertension can actually be cured or completely neutralized by a good lifestyle. And then, if medical treatment is not efficient, that means the patients are continuing to have angina, pains in the chest, or being short of breath, etc., then that raises the idea that a revascularization is probably needed, meaning one talks about stenting or bypass surgery. Now, which choice should we make? That's something that Professor Huber will be talking about also. As I said, long-term survival has been shown to be probably better after bypass surgery than stenting. Now, I also, I know Professor Huber agrees with that, is that it might be also, one of these things might be an effect of rehabilitation, because when you operate patients, they are, nearly all of them are sent off to a good cardiovascular rehab where they learn to change lifestyle, etc., while stented patients usually go back home the same day or the following day, and their way of changing depends very much on what their physician will be investing. I'm not saying, of course, that all patients should be operated. I'm just saying, and that's something that also Professor Huber will be going through, is that we must make a reflective choice where we keep one single aim. And that's what we always try to do in Swiss Medical Gate. We want to preserve the patient's interest first. That's the most important. That makes me come to the end of my presentation. I will turn over in a few minutes the chair to Professor Huber. I just want to check whether there are any questions. There it is.
So as far as I know, there is no question, but I will leave the word to Marina to figure out if there is any request in Russian that I cannot read at the moment or were not translated. But I would like to remind for the ones who came afterwards that you do have the possibility to go into the Russian room. For that, you just have to make your request by chat, and our webmaster Alexander will turn it on, for you, and you can join. Remind you as well, your connection by chat, it's for your question, either by chat, either in a request to do it directly to the doctor, and Alexander will do it for you. Marina, can you explain that again to them, please?
Yeah, thank you, Ingrid. Здравствуйте, господа, добрый день, все партнеры. Очень большое спасибо за то, что присутствуете. Если у вас есть желание слушать выступление на русском языке, вам следует написать в чате, что вы хотите, чтобы вас перевели в русскую комнату. Наш веб-мастер Александр это сделает. Спасибо большое. Приятного прослушивания и просмотра. Thank you. Okay.
Okay. So then I can continue. Okay, so then I will turn over the chair to Professor Huber, who is not only a friend, but especially the professor of cardiovascular surgery of one of the best university hospitals in a great region around here, not only in Switzerland, but a lot here. I like very much working with the Geneva Hospital, and especially with Christophe. So it's my pleasure to turn over the word to him, the chair rather, and he will talk about cardiovascular surgery. Thank you. Spasiba.
All right, thank you very much for this very kind introduction. It's my great pleasure to welcome you here from Geneva. We're right now at my cardiovascular surgery division at the University Hospital of Geneva in Switzerland. And without losing much more time, I will go forward with my presentation that you should be seeing shared on the screen in a few seconds. We get out of this one more time. Try to get this one up. Now you should be seeing the new one.
I'm sorry to interrupt you, Professor. May I ask again the participant to turn off them on mute, please? Because we can hear some of you and then we cannot hear Professor Huber. Thanks very much.
So I do understand that you have patients that are suffering and that you would like to take well care of. And my aim today is to show you the reasons why you should feel reassured to bring your patients to Geneva so that we can help you with taking the greatest care possible of your patients. Now, let me give you a brief introduction to the University Hospital of Geneva. This is the largest Swiss university hospital, has been founded in 1535. But has been totally modernized since, so don't be worried about that. We right now have about 1,800 beds at disposition for our patients, and it has been fully modernized, as you will see in the coming slides. the HUJ features a special private ward. So I'm not sure if you can see my mouse pointer, but if you can see, those two top floors of this building here are the top private wards. And of course, we have a full-blown ICU, we have emergency room, we have whatever you can dream of having, we have it in Geneva. So there are certainly no shortcomings. The private ward is shared by, or led actually by myself for all cardiac and for all surgical disciplines. And from the cardiac surgery side, we take care of all pathologies that one can think of belonging to the heart or to any kind of vessel in the body. It goes from coronary heart disease, without saying valvular heart disease, cardiac insufficiency, aortic aneurysm, so dilatations. So if the vessels become too large and looks rather like a bag than like a vessel, we take care of peripheral artery disease as well. So if you have a problem with leg perfusion, we would take care of that. And we even go to varicose veins, and we take care on adults and as well as of children. So if you take the sum of everything we do, we're one of the leading divisions in cardiovascular surgery in Switzerland, as we have cardiac and we have vascular surgery joined all in my own clinic. And then there's my partner, Remy. He is heading all the medical discipline on the private ward. And you feel free to use that link below to go and explore yourself the internet pages of the private ward. The private ward, that's about how the rooms look. I will get back to the essence why you want to come to Geneva. It's not the private ward, it's principally expertise of us surgeons and doctors. We'll get back to that. But on top of this, you get a really nice and comfortable room. You have concierge services with drivers, with catering facilities and everything you could think of as of a private division. And this being part of a university hospital that is quite rare or new in Switzerland. So to have a few words about my own clinic, I'm the chief of cardiovascular surgery. I have 3 staff surgeons for cardiac surgery. This includes adult and pediatric surgery. We are the largest pediatric center in Switzerland. We have 2 staff vascular surgeons for everything that touches vessels. So not the heart, and we have a full-time clinician only to take care of the patient of the ward. We have, of course, trainees and interns. We have 6 cardioperfusionists. Those are the guys who take care of the heart-lung machine during the operations. We have secretary, and a very important part of the way we work is everything we do in multidisciplinary approach. We want to take out the bias, of every personal bias of doctors in decision-taking in patients. We do apply best medical practice, and for this we need the help, and we partner up with intensive care, anesthesists, cardiology, radiology, angiology, neurology, internal medicine, and infectious disease, and many others that I haven't listed because of place constraint. Now, a few words about myself. You can find some information about me on a special Wikipedia page, as I invented some of the transcatheter valves. So those are minimal invasive approaches, but also because of being on the CTSnet, this is the US webpage for cardiac surgeons, and I have my own webpage as well from private nature, where you can find a lot of resources and background information, curriculum vitae, etc. about myself, if you're interested in to read a little bit further. Since I took over my training, maybe a short few words about my training background. I've been trained mostly in Switzerland, but I've been 2 years at Harvard Medical School with Larry Cohn at the Brigham and Women's Hospital. This is one of the best cardiac surgery institutions in the world, in the US. I've trained there and brought back his techniques and know-how to Switzerland and now to Geneva. I've also trained in congenital, so in pediatric children cardiac surgery at Great Ormond Street Hospital in London. So one of the best places for children cardiac surgery in Europe for sure. And I've been for the last 7 years, before starting May 2016 in Geneva, the leading surgeon in Bern with my former chief. They're doing about 300 operations myself per year. This is about the largest volume that you can get in Switzerland by a single surgeon. I've also been awarded Best Cardiac Surgery Trainer of Switzerland by the authorizing body, government body of Switzerland. I've had quite a few publications in transcatheter valves, in minimal invasive, in cardiac surgery overall. Also, I'm the author of the first transcatheter valve book in the world. This is called Transcatheter Valve Therapies, has been authored by myself and Ted Feldman, an American cardiologist. So what do you have to offer, and how do we work? The special way of how, or what I have put in place in 2016 is that we really want to move the patient into the heart of our profession. And it's not good enough if there's one cardiac surgeon that says, we have to operate the patient. This has to come from a team approach where we look at all angles at what is best and what is the most tailored, personalized treatment for that particular patient. So it's not good enough if you knock at the door and the surgeon say, no problem, I can operate. Of course, we can operate all the patients, but is it really the best, in the best interest and best care of the patient? And we really thrive all together in Geneva to that kind of approach, to get the maximum of collaborative approach. And this short video that I want to show you illustrates, of course, a few nice images about the heart. And toward the end of the video, you will see how we collaborate. Every patient that comes has a personalized consultation, and we really go into details. What are the patient's needs? What is best for the patient, and what should not be done? Because sometimes it's more difficult to say no to a patient than to say yes. And as you can see here, this is the structure of the heart. The heart has a left and a right side, and different disease can be found. Cardiac surgery has been very popular in Switzerland. Switzerland is one of the leading places of cardiac surgery in Switzerland. And we have really the top-notch technology with all the imaging that you can imagine. And as you can see here, all patients once a week, every Thursday at 4 o'clock, as it will happen today again, we discussed every patient, and there is a multidisciplinary approach of many different colleagues that will all join and take a joint decision what's best for the patient. So it might be no surgery, no stenting at all, but just lifestyle modification, medical therapy, and then the next step might be stent or surgery. This is, I think, is very important because many private clinics just try to go what is most interesting in financial terms, and it's not in the best interest of the patient. Let me give you some few short background information about this incredible organ that fascinates me every day. And I agree, I have the privilege of every day seeing, touching, and healing hearts. Well, I don't heal, it's nature that heals, but we give what is needed so that nature can heal what needs to be healed again. So this incredible organ, it pumps 2,500,000,000 times in a lifespan. If you take a patient that will be 80 years old with a frequency of 60 beats per minute, and it pumps 151 million liters. So this is the half the volume of this great Alexander supertanker. That's the incredible amount of blood a heart is able to pump, and it does that without telling you anything. You don't hear, you don't feel it, it's just there doing a silent job. And of course, if somebody does such kind of incredible work and job, it can become diseased. And then it is very important that you listen to your heart, because your heart will tell you very soon something's not going right. Another example is really fascinating. If you take all the millimeters, centimeters, and meters of vascular, of vessels joined together, you get 100,000 kilometers of length, of vessel length in one patient. That means 2 times the circumference of our Earth. Every time the heart beat, it pumps blood around 100,000 kilometers. This is just amazing also for us. And let's spend a little bit of time of that in that interesting video. I will stop talking now. And I'm pretty sure you all know about this. And what we want is to prevent, under all means, that it happens, this kind of flatline. And I want to show you this picture. This picture has been drawn by an artist that worked for Ciba-Geigy at the time, and is world famous, this picture, because you see a man that gets out. And this illustration really shows you everything you should know about how the heart talks to you. This gentleman is middle-aged, he's certainly manager, he's well-dressed and comes out of a well-heated restaurant just after a happy dinner with some alcohol, nice and good food, and then he walks up the stairs, but he comes back right now from a business trip, as you can see by his suitcase, and as you can't see is that actually he threw away his cigarettes a little earlier, and what he does is he puts his hand on his heart, and this is the typical angina. This is the pain the patient feels and makes you feared that something is happening. And this is really illustrating what you should show your patients, that if you feel that, this is an alarm sign. Your heart is talking to you, so listen. And make sure that you don't only look at the patients, male patients, but women are also at risk, at least as much as men at a certain age. So please don't forget about them. So let's have a look at coronary heart disease. Well, what happens is in the arteries, well, there's some plaque starting to build up. There are fatty layers, there are muscular tissue, there are calcifications, there are many things in those plaques, but for a long time they remain silent. And here, if you have lifestyle modification because you have identified the issue, because you looked for it, well, then you can reverse things. But when it starts happening and becoming progressive and more and more severe, then it starts also being more visible, or it will talk to you. You will start feeling, patient will tell you that they have angina. At the first stage, it will be stable, then it becomes unstable until you get a full closure, and that's what we call infarction. And this is the mishap that shouldn't happen anymore nowadays. If you do regular checkups, you don't get further like that. You do lifestyle modification, you can stabilize things. Of course, if you get to stage 2 and stage 3, then you need probably more than just medication, then you will need surgery. So what about disease and stenosis? It's nothing more than a big traffic jam in one of the main leading axes into city. And what we need to do is to fix those traffic jams. So let's look at this picture. You can see here the traffic jam leading to a very old broken bridge. That's the diseased vessel. And I leave it up in the air, but would like to address the question to you. How would you really fix this bridge? Now, I'll give you my answer because I can't listen to all your answers, but my answer is a surgeon perspective. I don't think putting a stent into a bridge like this and trying to fix things here will really justify and make things better. It might help a little while, but then you're back to zero. So what is surgery doing? Surgery really goes beyond. Surgery looks at where's the disease bridged, and then it's going to create a new road and an additional way to have the circulation going into town, have the blood to get back into the muscle without touching anything that is diseased, because the stent actually replaces a diseased segment with a foreign body that actually for the body is exactly as diseasing as the old disease was. So what we do is we put a bypass graft, we put new tissue, patient's own tissue, beyond the region of disease. And as you can see here, we don't fix the bridge, we leave the old bridge, but we construct a very new, modern, fast traffic bridge that will be the patient's bypass graft, as you can see here. So that's what we do as cardiac surgeon. And ultimately, all the studies show that in the long run, cardiac surgery outperforms by far any kind of interventional cardiology. Of course, I have a bias. I'm a cardiac surgeon, but I'm also, my bias is based on of very recent publications that actually have been published by our friend cardiologists, so that I can say the cardiac surgery bias is out. Now, what we do to do those bypass grafts, we need to get access to the heart, and we need to have the heart somehow being arrested. So you need the heart-lung machine, and you will get some background information about heart-lung machine. This is a typical video of what we do when the heart is arrested. You can see here, this is a coronary artery, it measures 1.5 millimeter, and you will see a droplet of blood. So don't worry, if you don't feel good looking at blood, don't look, but it's gonna be a very tiny droplet, that's all you see. And there is no messy, no blooding around. We're gonna enlarge the vessel, and in the next step, we will suture a graft. So imagine you can see everything magnified. We have loops when we operate, as well as the camera now shows you a magnified view. It's again 1.5 millimeter. The suture we use is as big as one of your hairs. And principally, what we call creating an anastomosis. It's a connection between the coronary artery and the new vessel. So with that, we really bypass, we go around the stenosis without touching the diseased part. We go right into the healthy part to make sure the patient gets healthy, good new blood. So let me keep a little bit of time, spend a little bit of time on minimal invasive. There are many, many ways of looking at minimal invasive cardiac surgery. First of all, make sure that the word minimal invasive is not a catch to get a patient and apply a non-suited treatment modality, because what's the benefit of the patient really minimal invasive? Well, it can be aesthetics, a smaller scar, but still a scar, faster recovery, sometimes yes, not always, shorter hospitalization, less transfusion. And I show you this image of Marilyn Monroe for a reason. You're probably not aware that she had a big scar here on her right abdomen for a cholecystectomy. But nevertheless, she chose to go through real surgery in order to have a proper job done. Because when you limit yourself for aesthetics reasons, you have to bargain and you have to somehow decrease the security of the patient in order to get a nicer scar. Now, is it really worth, when you do cardiac surgery, to win 2-3 centimeters shorter scar and compromise really safety for the patient during the operation? Because it will need longer operative time if you go small. It needs longer heart lung machine times if you go small, and you will also have less complete surgical outcomes when you go small. So small can be good, but be careful, it's really the right thing for the patient. So small not always means better for my patient. We compare apple to pears, and many people try to have more patients to attract them by selling them, we can do it small, but don't telling you we also take larger risks. So yes, if you have a very young patient, it can be nice to have a nice small scar. But if you have a patient that is 78 years old, the scar is really the least of its concern. The most important part is a durable, good quality job. So what have we, for example, implemented in Geneva over the last years and since my approach in CABG surgery? Because I discussed a lot on coronary artery disease and how we treat them. Well, first of all, and this is part of the whole strategy, is a multidisciplinary approach. So many people will give their advice. So it's not one person just deciding for the patient, but there are many other people that all have expertise, very important expertise, that will be joined. And together we are stronger. Then when we stop the heart, we need a cardioplegia. This is a solution we'll show you later that we inject into the heart to stop it. Again, there are different ways of doing it, but I'm sure I can convince you by what I will show you why the way we do it in Geneva is probably the best for the heart and the patient. Then we use minimal invasive heart-lung machine. Our heart-lung machine is a quarter as big as the normal ones. So it's less trauma for the patient, less inflammation for the patient. And for every patient we operate, we do intraoperative quality control. So we really check if what we have done is the bypass graft really performing optimal during surgery and not only afterwards. And then we use, whenever possible, arterial, full arterial revascularization. So this is this miraculous liquid here. It actually needs only 100 milliliters. So a small cup to stop a heart. And as I said, this is a standard heart lung machine. This is the S5. This is newest generation we have at the HCG. But if you go for CABG, we use this little thing here. And this heart lung machine, if you compare it to the first one, well, it's 1/4 of its size. And that's all we need when we do CABG grafting. So that's what we call minimal extracorporeal circulation, MECC. It's a closed circuit with very short tubing. It's a centrifugal pump. This means it's a pump that is atraumatic. And it's completely biocompatible, and it needs only a single shot cardioplegia. And I'd like to show you this. This is a heart that is beating. I hope you're happy to look at that and you don't worry too much. The patient has been fine. And you see we clamp our aorta. This is the main vessel. And then we inject this. This liquid will be injected. And look at the heart during injection. It takes 50 milliliters and the heart is stopped. The heart is stopped already. It not even took 2 seconds. This is the less traumatic way of stopping a heart. And the advantage of that is that, as I show you in the next video, when you take the clamp off, so now look at this clamp, the heart is stopped. Now focus here, we just remove the clamp. That's the clamp that has closed the aorta. And look what happens to the heart. It's not like in movies where you see those guys putting electricity on the heart. And as you can also see, these are very small scars. So we make small scars, but we open the sternum fully. So we have both good aesthetics, but also a good trade-off regarding the security of the patient. And the heart beats normally again without any additional help. And this is something you will all find in Geneva if you go to search for any place in Europe. So again, this is what has been titled when I came to Geneva in May 2016, a revolution in cardiac surgery through integration of heart team, putting the patient really at the center of our profession, standardized surgical hybrid approaches that allow us to be less traumatic with smaller machines, smaller heart-lung machine, faster recovery of the patient. And I really emphasize on that part because this is what you have, wherever you go, if you choose another place, it's fine with me, but make sure it is a true multidisciplinary heart team approach if you want the best for your patient. And we not only operate CABG, of course, we are also state of the art for valve procedures, aortic stenosis, mitral regurgitation. We use different prosthetic valves to do that. We also do artificial heart implantation, assist device, so all that you will also get in Geneva if the patient goes into heart failure. But this, of course, are more demanding, but it's to show you our expertise that goes from the very basic to the most advanced treatment in cardiac surgery. And for one of the last videos that I want to show you is just to give you an overview of our brand new OR. We're very, very proud. This has opened 1.5 years ago. It's a totally new OR. You can see there are large screen. Everything we do is filmed, so everybody can see what is being done. Everything is perfectly transparent. If the anesthetist is here, he observes whatever is happening on the surgical side. And we have really all technical facilities that you can dream of. We have them here in Geneva. So I'm happy to welcome your patients anytime here in Geneva if you feel comfortable to send them to us. And with that, I would like to show you just a small last video because this is an amazing part of Geneva. It's also technical, nearly miracle. This is the jet d'eau. It's also a pump that pumps water up to 140 meters in height. And there is 7 tons of water that are permanently in the air. I have to go down with the sign. That are permanently in the air because of technical engineering of our colleagues here in Geneva. With that, I'm happy to answer questions if you have questions. Thank you very much. And I will stop the screen sharing so that we get back to the normal screen.
Thank you very much, Professor Huber. That was extremely interesting, and I perfectly agree with everything. So,
Dr. Rabaeus, there is a few questions for Professor Huber. Can you have a look at it? And there is quite a few of them sent by someone under the name of iPhone, and there is another one from Irina. So if you could just have a look at it.
I'll go to the first question concerning the minimal invasive surgeries. We are very interested in TAVI in particular. We have a patient who is in need of it at the moment. We have some inquiries. What are the 100% indications for TAVI? How much costs? How long the patient stays in the hospital after the surgery?
Thank you very much for this question. So it is very important to, first of all, really understand if the patient needs a TAVI or something else. TAVI is a technique that I have helped developing in already year 2000 in order to really help patients that are at high risk for surgery, at too high risk for surgery, patients that are maybe too old to really take the full profit of surgery. So if you have a patient that is 78 years old, you shouldn't go for TAVI if he's in a good clinical condition. I would really say this is a wrong way to go. If the patient has a lot of comorbidities, so let's say he has problems with his lungs, problem with his kidneys, he might not have all his head, as we say in French, together anymore, then TAVI is a good option because this patient will not take the profit of a long-term treatment. For example, if you put a TAVI in, we know that the TAVI will last about 5 to 6 years probably, but not much longer. So what happens afterwards? putting 2 TAVIs in the same patient is probably not the best thing to do, for example. And I really think, first of all, of course, if you read the news, you see TAVI is nice. You don't need to cut open a patient's chest. It's a quick fix, but unfortunately it remains a quick fix, but it's another long-term treatment. Now, if the patient really is a patient, as by the recommendation, has Euro score of more than 10, STS score of more than 4, won't go into details, but those are risk scores that we use to evaluate the risk of surgery and then exclude surgery in those patients. If the patient can tolerate surgery, well, then give him the chance, but he will get a valve that lasts 18 years. So that's an 18-year success. If he's not a candidate for surgery, then we will go for TAVI. So TAVI is an intervention that will replace the old valve, but leaving the old valve in place. That means the old valve is not being removed. You just leave the disease and you push it to the side. And probably because of that, it's also one of the reasons why TAVI is not as successful as surgery. Unfortunately, there are a few publications out that show short-term it's equivalent to surgery. Yes, of course, within the first 30 days or the first year, well, it seems to be equivalent, but what they don't tell you is what happens afterwards. Now, if after 4 to 5 years those valve fails, what's then? Then we're going to do surgery on those patients. So really make sure that that's why I so much insist on the point. You have to have a heart team that looks at the patient and decides if TAVI is the right thing to do, well, we will do it for him. But if it's not the right thing, then go for surgery. It's a long-term fix.
What is the procedure cost? Do you have an idea?
Well, TAVI is very similar to cardiac surgery because the device in TAVI is 30 to 40,000 Swiss francs just for the valve. So then you add, it's about 7 days of hospital stay. You got very close to the 100,000 Swiss francs you need as you would need for a cardiac surgery. But if you get cardiac surgery, you have a long-term result. If you have TAVI, it's a short-term result. But spending is not much difference.
Just to conclude on that, if the patient prefers to have TAVI and refuses open heart, would it be possible to do the TAVI then?
Well, first of all, we have to talk to the patient and really understand, why do you refuse? If you refuse because you are scared, well, then you have to tell the patient that the risk for a complication like stroke is higher in TAVI. The risk of dying is as high if you do TAVI as you do surgery. So what is really the benefit to do TAVI? Is it just because you are scared? Well, if it's scared, then it's not a good feeling. We should get to the base and to the real reason why not having surgery. It's like if you choose to drive somewhere, well, you can drive safely and spend a little bit more on a big car. This means spending on, not in money, but investment-wise, in a bigger car, but you're sure that you have airbags and you can drive long distance. But you can also say, well, I really only need a small car anymore because I'm happy with the next 4 or 5 years. I'm anyway going to die. Well, then take the small car, and that's it's a good solution. But it really needs to be patient tailored, and it's a wrong reflex to say, well, there's something to fix, so let's fix it with TAVI. We won't be happy at the end, and your patient won't be happy at the end in the long run. If it's well chosen, then everybody will be happy.
The next question asks, how long are the stents effective after being inserted? That's a difficult question to answer. I would say that that's the whole problem. The problem is double, because it's not only the fact that the stent can get stenotic again and get blocked, but it's also that the stent, as I was talking about the lifestyle, know that the stent does not influence all the other plaques that might be present on the arteries, and that will continue to evolve if you don't take action against them. And that's why, but usually, I mean, a stent in itself can last for several years, that's for sure, even very long. But it's also true that depending on how the patient takes the medication, etc., they can get blocked very regularly also. They are sometimes absolutely needed, especially on a short term, when you are close to having an acute blockage. But again, I'm not saying that one should stop putting stents in everybody and so on. I say more that we have to be much more choosing exactly what we want to do. As Professor Huber was saying, is by discussing, I mean, having a global team approach and not only the one who is first there to do. And that's why personally, I very often try, for example, I know that because that's a simple way of doing it, instead of doing a complete catheterization when you are suspecting something, you do it with a scanner. Because if somebody is there and seeing a stenosis, he will put in a stent, because that's what we call in our jargon the oculostenotic effect. I mean, you see something, you have to solve it. So, but I do insist that whether you have a stent or bypass surgery, the way you are going to treat yourself is very important, which is the secondary treatment, especially the lifestyle.
Maybe I could add, Michael, just if you look at the study, I mean, I would invite everybody of you, you can look that up in Google, is the Excel trial. Excel trial was a study driven really by hardcore cardiologists that believed in stent. The only good thing was stenting. And the Excel trial 5-year results, so I only talk about 5 years, showed a huge difference in survival between patients that got bypass grafts who all survived and patients who got stents who didn't survive. And this was a very, very big disappointment for the cardiology. And the other thing is another study that came out just beginning of this year. It's called the ischemia study that showed actually if you have patients with stable coronary heart disease, those are patients that are on a stable level, they don't get worse, they have disease in their coronaries, but it's not clotting completely, and they live a stable life with that. Well, actually, those patients have no advantage whatsoever to get a stent. Also, stents don't give you a longer life expectancy. We know that. Stents are good in acute infarction. They outperform cardiac surgery. If a patient comes in a really acute infarction, they're better than surgery as means to save the patient. They're also good if you have only one vessel that is diseased, if it's not too close, too proximal as we call it, and not too distal. So it's very choosy, but and if the patient has diabetes. If you have diabetes, 2 or more vessels, or if he has what we call left main stem stenosis, that means the main road before it starts bifurcating in 2 vessels that is diseased, then go for surgery and you will get a much better outcome in the long term. And that's also what most studies nowadays in cardiology tell us.
If I may add to that, yes, I agree totally. And I think that the most important thing is just to realize that when you do discover a coronary artery disease, it does not make it evident that 100% of these people should have some kind of revascularization.
Oh, yes.
And the moment you choose that a revascularization is needed, then indeed it's probably surgery which might be which very often is better indicated. There was a question, is there an age limit for surgery?
Well, this is an excellent question. So first of all, Professor Dukki is one of the pioneers of cardiac surgery. He was 96 years old when he was operated for a dissection in Texas. And this is the procedure that he himself developed and invented. Well, actually, the answer is yes and no. I think there's a reason. First of all, it's not a numerical age. It's the biological age of the patient. The patients can be 70 years old and look like 95. And these patients, I wouldn't touch as a surgeon. That's why, and that's what works very good. We look at the patients and then we decide and say, well, this patient actually might be young, but he is already much older and diseased than his age would actually tell to be. So those patients then would profit of non-invasive, non-surgical options. So first of all, what's the biological age? And therefore it's important to see the patient, to speak to the patient, and to be, well, not only one person speak to the patients, but several specialists. That is a very important part. Then if the patient, yes, is 82 years old and in good shape, well, you need to know that most of the real challenging operation we do at night for emergency reasons happen in patients that are 80 years, 84 years, and those patients get the real big operation, not the small CABG and aortic valve replacement operations, and they do fine. So is there an age limit? It's difficult to say. There is probably from 85 years onwards, you really have to think twice if it's really in the best interest. I would say, let's say if you are 82, 84, probably a TAVI for aortic valve is a good option. if the patient is really fit. I just operated recently a patient who is doing a lot of tennis. He was operated 2 months ago. He was supposed to wait 3 months before starting tennis. When I saw him at 2 months consultation, he said, I'm back in tennis. And he's a good friend of a cardiologist in town. He was a patient we operated, 83 years old. So what is the age limit? Look at the biological age of the patient. That's more important than the numerical.
To come back to the really important principle to end this session is that it's the patient's interest that comes first. And we always come back to the same thing, that it's not a question of a figure on the paper, things like that. It's what can I do to help the patient or in the best way. And intervention is sometimes much better, and sometimes it's much better non-intervention. And that's the whole discussion we are having. And I think we reached all the questions then. So thank you very much. It was a great pleasure. And I turn back the word to Ingrid. You close.
I will do so, but I will add something which is very, very nice. We got a message from Irina. So thank you to you, Irina, to let you share this. Actually, we could not hear it, but it seems that your presentation, Professor, had a big applause in the Russian room. So I would like just to share that with you.
Thank you.
Thank you very much.
So thank you, Dr. Rabaeus. Thank you, Professor Hubert. Our next webinar will be held on Thursday, the 4th of June. The theme that will be discussed will be obesity, overweight, and endocrinology by a big and famous professor as well. So once again, you will receive the information and registration form if you are interested. I will leave now the final word to our Managing Director, Marina Verbitsky, and thank you for your participation. Thank you and goodbye.
Thank you.
Thank you all. Спасибо большое. Thank you, Professor. Thank you, Dr. Rabaeus. We will see you next week. It was very interesting and very, very impressed presentation. Thank you again and bye-bye. Ciao.
Thank you very much for the interest. Bye-bye. Take good care of your patients.
Okay.
Thank you.